Solutions to Achieving Health Equity, a guide to healthcare professionals. This book is hot off the presses and authored by one of our very own National Medical Association members, Dr. Mauvareen Beverley. She's a physician executive with over 20 years of experience advocating for improving the patient engagement and cultural competence for all populations. As the Associate Vice President of Physician Advisor for New York City's Health and Hospitals, she was the first to develop a care management program for sickle cell disease. She also managed the first sickle cell support group, which is still in effect today. Dr. Beverley, in addition to being one of our cherished members at the NMA, is a fellow of the New York Academy of Medicine, a member of the National Association of Health Services Executives, the AMA, and the Medical Society for the State of New York. She's also a physician advisor to the Westchester Sickle Cell Outreach Organization. As you will learn in her book, Dr. Beverley received her bachelor's from Boston University and her medical degree from the University of Buffalo School of Medicine. Also in her book, she talks about Harlem Hospital, where she did both her internship and her residency. She is currently president of Mauvareen Beverley, MD, PLLC, a patient engagement and cultural competency specialist, and she has developed a patient engagement and cultural competency training program that was accepted for presentation at numerous health systems and medical schools. 9 Simple Solutions to Achieving Health Equity, a guide to healthcare professionals, is also a bestseller already. So thank you for joining us, Dr. Beverley, for sharing the great work that you've done putting this book together. I'm so excited to talk about this book tonight. And I want to start with the basic question. What prompted you to write this book? And tell us what sets your book apart from others on the topic of health equity.
Thank you, Joy. This is an honor to be with you and to have this discussion on my book, 9 Simple Solutions to Achieve Health Equity. In terms of your question, what caused me to write this book? It came from speaking to over 1,000 patients from all race, ethnicities, while developing, as you mentioned, the first care management program at New York City Health and Hospital. It started at Queens Health Network, which was Elmhurst, which is a large Asian, Hispanic, and a growing Russian population. And at Queens was a large Black population. And the second population was Indians, but they were not from India, they were from Guyana. And just on a side note is I created the concept of the bridge team, the whole idea and the bridge the gap. Particularly, I don't care what the gap is, the bridge team was responsible to bridge the gap because they had a little extra time to speak to patients and then give that information to the actual clinical team. And we went in just on a side note to see a patient, he was Indian, and one of the care managers said, "Oh, where in India are you from?" And he said, "I'm not from India, I'm from Guyana. I'm not," and it's what I realized, what I call the lookalike syndrome, So, when I do presentations, because that was the key moment, So go tell a British person they're Irish and see how far you get. Go tell a Chinese they're Japanese. Go tell an Indian they're from Pakistan, and go tell a Trinidadian they're from Jamaica. And equally important, go tell a New Yorker that they're from New Jersey and see how far you get.
Tell us what sets this book apart, though, Dr. Beverley.
Yeah, I'm going to tell you. And it sets it apart because what I realized after speaking to over 1,000 patients from all ethnicities, as I mentioned, and race, is that the patients are not included in the solutions. And in my book, the patients are a big part of why I developed the simple solutions. And some of it came from what I describe as stop in my tracks moment. And the populations were so diverse because included in that was Kings County, which I call the merging of the African diaspora. There were Caribbean population and African-American population. And the Spanish population was from Panama. They were not typical from Puerto Rico, Dominican Republic, or Mexico. And under colonial rule, the British sent the English-speaking Caribbean to Panama to do what? Build a canal. And so phenotypically, they look Black, and they have English and Spanish name, Ronaldo, Austin, Antonio, Martin. And their primary language was English. So when you think of Elmhurst, Queens, and King, it's a merging of, different race, ethnicities. And as a result, I spoke to over 1,000 patients. And that's when I came to the conclusion that in speaking to these patients currently, in any time you talk about health disparity or health equity, patients are not included in the solution. And in my book, the uniqueness is that the patients were an integral part of the solution.
Thank you for that. I really enjoyed reading this book, and I see that the patient stories and patient experiences are woven throughout. So I'm excited about talking more about that tonight. And again, I want to thank you all who have joined us. If you have questions, you can begin putting them in the Q&A portal, and we'll be addressing those questions at the end of our talk tonight. Dr. Beverley, one of the quotes that I read in your book that really struck me, and I'd love you to help me understand, it says, English-speaking Black patients are not included in the need for cultural competence. Can you explain what this means and give us a little bit of background on that?
Okay, yes, very important, because what I realized when I was Deputy Executive Director at Kings County, and my role was to expand the care management program, but I was responsible for the 30-day readmission prevention program for heart failure. When Medicare came out and said if the patient came back in 30 days, we would only pay for one admission. Whereas prior to that, they would pay for 2, 4, 6, 8, 10 times. And so if for no other reason financial, institutions across the country had to develop a program. And obviously heart failure is age-related. The bulk of the population were between 60 and 92, even though we did have a 23-year-old, which we referred to as our baby, the team. And, but that's when, in speaking to these patients, the elderly Black population, it was humbling. And that's when I realized, and I'll give you an example. So I told the team, because it's the merging of the African diaspora, we need to know who is Caribbean, who is African American. We want to know, do you live in New York and you got sick, or were you visiting for an event, a family reunion of some sort? So we went in to see a patient. She was 80 years old. And I asked, where are you from? And she said, South Carolina. And I think it was important. My next question from a medical perspective, I want to know, do you live in New York, or were you visiting? Because if the person was visiting and they got sick, the transition of care would be different than if you live here. And Joy, once I said, where are you from? So I was about to ask the next question, do you live in New York, or are you visiting? She said, my parents were a step away from slavery and my grandparents were slaves. Monday morning, 9 o'clock. Was I expecting that? And I said, tell me about it. And she said, my family picked cotton on a plantation that was not ours. And then we had to get up at the crack of dawn and pick 300 to 500 pounds of cotton. And I think that's the same amount of numbers that were in the movie 12 Years a Slave. And then I had to walk 10 miles to a segregated school. And I'm thinking, 10 miles? Oh my God, we can't even go 5 blocks without calling an Uber,
Right.
So then I said, how do you walk 10 miles? And her body language changed. And she said, and a tone, she said, well, if you want an education, you had to. Like, what part of this don't you get, stupid? And I said, did you have to walk back? She said, no, the principal in the horse-drawn carriage took us back. And we had to get back before dark, before the Ku Klux Klan. I said, how old were you? She said, 10 years old. Can you imagine? And I said, she continued her education. She went to Voorhees College, it's a 2-year Black college in South Carolina. And this was 60 years ago. She's now 80. You know what her next statement was? She was still upset with herself. She said, I didn't get until my second try. She was still upset with herself.
Wow.
And she came to New York, and that's when the migration, when people left, African Americans left the South because of Ku Klux Klan, lynching, and Jim Crow. And they came, and most African American men were either working in the subway system, maintenance, or doorman. And she got married, continued her education, became a dietitian. And her 2 children were 2 of 5 Black children to integrate Stuyvesant High School. And, you know, and that's what I'm saying, they're in our hospital beds and not in the history book. And so I said to her, you know, you're going to need home care. And she thought, you know, had given her a handout. And I tell my team, when you mess up the problem, I mean the communication, apologize.
Yeah.
She said, I don't want anything that's not mine. So I said, I'm so sorry, I didn't explain it correctly. I said, everyone that has Medicare, home care is a part of Medicare. She said, everyone. I said, yes. And she said, okay. So this is where we realized that this cultural competence does not apply to
English-speaking Blacks.
Black, exactly, elderly.
Interesting. So let's talk about, and you mentioned it a little bit right after the introduction, and this is something that I was particularly struck by in the book. You mentioned these stop in your tracks moments. Tell us what a stop in your tracks moment is, and let me know what that means.
Okay. So, you know, when I developed the care management program, and, you know, I think I have all the pieces of the puzzle essentially.
Yes.
Move the dial to improve the health for the most vulnerable. In Queens, one of the most vulnerable population were patients with sickle cell disease. And these stop in my tracks moment, which I'm going to explain, is what led me to Boots on the Ground Simple Solution.
Okay.
I went in to see an 18-year-old patient with sickle cell, and everybody was saying, she's attitudinal, disrespectful, you know, she's always in the emergency room, you know, drug seeking, the whole nine. And I'm thinking, what 18-year-old is not attitudinal without a life-threatening condition? Let's give her the benefit of the doubt. And I was about to enter her room with the team, the bridge team, and she said, she went like this, I'm on my phone. So I said, okay. And the team is whispering, that's what we're saying. She's so disrespectful. So she got off the phone, and we're about to enter her room, and she said, if you have a cure, come in for my disease. If you don't, and she went, keep walking. And I said, oh my God. So was I expecting that? I literally remember.
You literally stopped in your tracks.
It's tracks, exactly, stopped in my tracks. And then she said, the next statement, I became the child and she became the adult. Why do I say that? She said, did you hear what I said? I'm going to repeat myself one more time. Isn't that what we tell our children when they're not following directions?
Yes.
If you have a cure, come in. If you don't, keep walking.
Hit the road, Jack.
Yeah, so I said, I don't have a cure, but let me think about what you said, and I'll come back and see you and meet with you that evening. And when I met with her at 5 o'clock, who she was in the morning was who the system created. She was in the evening was who she actually was. A very intelligent, very you know, concerned and very caring person. And she said another powerful statement. You doctors don't teach me about sickle cell. Sickle cell teaches me. And then she said, tell me about yourself. She's 18. At 16, her mom got off the bus from work, developed chest pain, was taken to a hospital and died of a heart attack. At 17, her sister got admitted for sickle cell crisis and sepsis and passed as well. She's now 18. She lives with her uncle, and the way she described him is like a food, shelter, and clothing type of guy. And again, she said, you doctors don't teach me about sickle cell. Sickle cell teaches me. And we hugged each other. And I said, have you ever been referred to see a therapist, a psychologist? She said, no. Have anybody ever asked you to get depression screening? She said, no. And it was those stop in my tracks moment that caused me to go down to the emergency room, the head of the emergency department, and to discuss how we would treat patients with sickle cell when they came in, and would they be willing to sign up for a sickle cell support group.
Sure.
So the care managers, if they came in, they would sign up, and we had about 16 or so patients, and we had it at lunch, and it was an hour before hematology, and we provided lunch. And the meeting was unscripted. Patients could say whatever they want, and we had a therapist on the team as well. And when you hear the story, you know, I heard the word hate a lot. I hate my mom. I said, oh my God, how do you hate your mom? You know, as a mom. She said, oh, I don't hate her now, but I know she loves me over the moon. and she wants the best for me, but I never understood when I was younger, why did she side with the doctors and keep me in so much pain? Why didn't they just let me die?
Mm.
And then the other thing, and that's what I'm gonna say, then I heard, my brother hates me. Why does your brother hate you? Because I suck up all the oxygen in the room.
Yeah.
He has sickle cell, he does not. And the brother was on the basketball team, never went anywhere. All of a sudden, he goes to the semifinals, and
Yeah.
their final is tomorrow.
Remember
And
this.
mom and dad and her were supposed to go, and she developed sickle cell crisis at 1 a.m. and the mom and dad had to take her to the hospital, and he had to go to the game by himself. And this was when I realized that family counseling is not even thought about for patients, families with sickle cell disease. Because I did research and I asked a lot of organizations, do you provide family counseling? And everybody said no.
So it's almost like these stop in your tracks moments, like that all of us have throughout life, that moment that you just pause, like, what just happened? Let me process that. It actually created this desire in you to go deeper into the patient experience, it sounds like.
Exactly.
And out of this patient experience then was born this book and understanding the importance of patients in the health equity discussion. Am I right about that?
Yeah.
Okay.
But also to change the emergency room, how patients are treated.
Sure.
And in Queens, now they had a physician assistant who saw the patients when they came in and would notify their doctors that John Brown is in the emergency room. So it was a much more caring, and also they were part of the observation unit. And what I think is more important or equally important is that the innovative processes that I developed, which include the stop in my tracks moments, in terms of developing the sickle cell support group, is still operational to today. So there's sustainability in the process. And that's what, to me, my book is about, to create systems and to create processes that are sustainable.
Sure. There's another, I'm so sorry for the interruption. It just made me think about another quote that I read. I didn't ask you about this earlier, but another one that really struck me. It says, difficult patients are not just born, they are in part created by their passage through the medical system. Please speak to that a little bit and tie it to, again, the purpose of how this book came about.
So the reason why that is important is from Dr. Zemsky, who is a pain specialist in Connecticut, who deals a lot with sickle cell patients, and he wrote an article, and that statement came from Dr. Zemsky. Difficult patients are not just born; sometimes they're created through the medical system. Not only the system failed to cure, it may have done not so nice things to make matters worse. And the reason why I put that statement in the book, for patients with sickle cell disease, if they go to a hospital and they're in the emergency room and they're not being cared for in a timely manner, which has been shown in the medical literature, sometimes patients with sickle cell, they're in crisis and they wait 6 hours before anyone sees them. And I said, put that statement in your phone. And so if you're not being cared for in a timely manner, and if you're in so much pain that you can't repeat it, have a family member, show that statement with Dr. Zemsky and tell the doctor, please don't do unpleasant things to make my condition worse. Thank you. I need to be seen now. So could you imagine, let me just say, could you imagine if an African-American young person now shows medical literature to the doctor and says that, you know.
Meeting you where you are, doctor.
Yes, and so please don't do things make matters worse. And I said, and tell all patients and organizations with sickle cell, have them put that statement in their phone.
I really like how throughout the book you give both, and now it's really clicking for me. Now this book is not just for providers, physicians, but it also is for patients, because you give both partners in the healthcare experience guidance on how to create a better team along the healthcare journey. I really love that. This book, again, these 9 keys as it relates to health equity, and I want to share those really quickly. A little cheat sheet for those of you all on the call. We expect that you already have the book, are going to get the book, as we're not giving it all to you tonight. but I really just want to run through those 9 steps. And then I specifically want you to comment on a few of them. And I'll ask you to do it succinctly, but just enough to wet the whistle of those people that are listening. So those 9 steps, and I'm doing a little paraphrasing. The first, patient engagement and cultural sensitivity training. You talk about that as an important piece. The second is the concept of the common thread, which is the human experience. That really touched my heart. The third, never using the words non-compliant or non-adherent. I'm not a doc, but I've heard docs say this without asking the question why. If I'm a patient and I'm not doing something you recommended, there is a why, and that why is important. Number 4 is eliminating the term drug seeker, and especially, I know much of your work has been in the sickle cell community. And I know that is something that is very, very important in that conversation, that drug seeker term. Number 5 is providing and making sure you get a comprehensive social history. Number 6, the application of the SPOT, S-P-O-T check methodology, speak, pacify, outline, and take. Application of the change mnemonic. I love mnemonics. I was raised by a teacher and a preacher, so the mnemonics are in my blood. Number 8, that was number 7, is the change. Number 8 is this perception of patients, that survey. I can't wait for you to talk about that, because that really, as a healthcare administrator by training, that was something that really spoke to me. And then the last is the self-reflection practice for physicians. So let's just quickly talk about a few of those. Touch on the concept of the common thread, which is our human experience, and how that shows up in your book.
So the common thread is what I realized, and again, from talking to over 1,000 patients, what I see the common thread is when a patient is diagnosed accurately with a disease, it's non-negotiable. Non-negotiable. I did presentation at different hospitals. I did it, I think it was at Northwell, and I asked, I usually ask, so what is the similarity between a homeless person and a millionaire? And I remember the intern said, what? The only thing I could think about is that they're men. I said, there could be women too, but that's another story. But what is the common thread? Once accurately diagnosed, there's no human being on planet Earth to give it back. Billionaire can't say, I'll give you $1 million to take the cancer back. Oh, that's not enough. I'll give you $5 million. In life, we have choices. You don't like the school your kids go to, you could change. You don't like your job, you could leave. If you don't like your family, you could move to another state. If you buy something and you have a 30, 60, 90 days, you could return it. But this is the common thread applies to all human beings, irrespective of race, gender, ethnicity, socioeconomic status. I think if health systems understand that, they may be more empathetic and less judgmental, because the bulk of us taking care of patients never laid in a hospital bed. And those that do are women delivering life, and maybe patients are trying in some aspect to prevent death. And I think that's where I decided to learn about the common thread.
I love that as a concept, and the way you present it is it's a concept for the health system to kind of get that into their common conversation and that understanding. But it really is a personal concept, that the person that I'm looking at lying in this hospital bed has the same humanity that I have. Right. And they're dealing with something that if I were dealing with it, I would want to understand what's being said to me. I don't want to be called non-compliant. I want to understand the treatment methodologies, etc. So let's jump then to number 9. We're going to move around, because this sounds like a good segue to talk about that self-reflection practice, that moment when the physician becomes in their mind, and for a moment in that role play experience, the patient. Can you speak to that?
Yes. So when we graduate from medical school and we take the Hippocratic Oath to do no harm, and we go in and we're really ready to improve and treat patients and learn about disease entities. And I think one of the things that may be important is to think about, reflect, do a self-reflection. What would it be like if I went to the emergency room and I was there for 6 hours? What it would be like if now I was transported to radiology and I'm waiting in the hall for another 2 hours? What it would be like if I was admitted and the patient next to me coded, and the fear factor, how would that happen? And what would happen if I was MPO because I'm supposed to have surgery the next morning and I'm not, from 5 o'clock I can't eat anything, and then the surgery is canceled until about 5 o'clock that evening? How what would I think, you know?
Gotta start the clock all over again. I
Yes,
get it.
and so these are the things that, you know, and what if, you know, I'm given all these medications, and what if and I don't even know what they're for? I don't even understand. And what if everybody comes in at all hours of the night to take my blood pressure and vital signs and the whole nine? So how would I feel about that?
Hmm.
You know, and so it may be helpful before patients start their internship is to think about and self-reflect, how would it be to be a patient?
Mhm, mhm.
And how would I respond to that? You know, and so that's one of the key things that I think, self-reflection,
Mhm.
because like I said, the bulk of us never laid in a hospital bed.
That really surprised me to think that that's not a part. And those of you who are NMA members and have heard me speak before know I always joke about I couldn't pass that second chemistry class, so I'm not a doctor today. But I am surprised that there is not some type of experience in medical school that puts a learner, someone who's going to be a physician, in at least a role play experience about being a patient. That really was surprising to me that, in your experiences, that role play experience is after the fact. Once you are a physician and you already have your hands on patients. That really surprised me.
Yeah.
Let's take a look at number 3. This is a big one for me.
Mm-hmm.
You say never use the terms non-compliant or non-adherent without asking the question why. That makes
Yeah.
a lot of sense to me, but talk about that a little bit and how you found that to help in this process of not only writing this book, but also achieving some of the accomplishments you have in your career.
It was key for the accomplishments.
Mm-hmm.
So now we started out with non-compliant. So now there's a nicer word, non-adherent, you know.
Yeah.
It's like moving from health disparity, so there's a nicer word, health equity, you know, but there's no way to explain how we go from one to the other.
Sure.
So what I do is I give in my book stories that really results from what's the experience of the term non-compliant. And right now, there's in the medical literature, it shows that negativity in the medical record are geared more towards African Americans, particularly males. And this came out of the University of Chicago School of Medicine. And so I give you an example, and this was real stories, and I think this is where my book becomes very unique. 60-year-old African American male recently diagnosed with congestive heart failure returns 2 weeks later, heart failure decompensated due to non-compliance. So when that person goes up to the unit, you think anybody's going to care about that person? And so one of the nurses in the unit said, well, so he just got diagnosed with a life-threatening condition and he doesn't take his medication. I got other things to do. My team had to ask why. So why can't you? So he said, why can't you take your medication? I can't take the water pill. And the diuretic. I said, why can't you take, again, the why question. And I hope everybody that's listening is sitting down. So you hear his response. He said, I can't take the water pill. Why can't you take it? Because I drive the number 7 train. So
if you're in New Yorker, you understand that, right?
Yes. So he can't say the train is delayed because the driver has to find
he had to get out and use the restroom.
Yeah.
Right.
So the interesting thing, so when is your shift? He said 11 p.m. to 11 a.m. What do you do when you get home? I do some chores. I make breakfast. I take some of my medication, but if I'm going on my shift, I don't take the water pill. The same cardiologist who was ignoring him, we brought him in, and he said, okay, when you get home, take the water pill. It may wake you up during the day, but by the time it gets to your shift, you'll have less of a reason to urinate. But to the degree that you do, we're going to give you a cubicle to use in the private space when the train stops. You know what the patient said? If I knew I had to choose between peeing and breathing, I would have chosen breathing. You know. Now, expand the conversation. Do you know without the why question, that patient would have been admitted multiple times. And now you go from non-compliant, I'm sure they're going to go to the other negative word, frequent flyer. You know, and I can't prove it. There's just my thought that patients that are described as non-compliant without asking why, we literally turn those patients into frequent flyer because they have to negotiate themselves through the system all by themselves. So just expand it. So he would have been readmitted. And to the degree that he may have passed, at mortality, it would have said died due to noncompliance.
Mm.
And so my
Mm.
team it was a mandate. If they didn't ask why, they said Dr. B is going to bug out, you know? And
Yeah.
so every time we asked why, we were able to help to understand who that individual is, as opposed to what our perception is of that individual,
Yes. Yes.
you know? And I
Well,
just want to,
I was
I'm
going
sorry.
to say, just let me interrupt just before you get there, because I
Yeah.
want to get to that question, but I want you to know that this moment, I don't know the different participants that are on the line. I would expect mostly physicians, but I had my patient hat on while you were saying that. And I can think of the times in my patient experience where I've been non-compliant, non-adherent, and I can't think of a time, or many times, I can't think of many times when the physician asked me why.
Yes.
Because then that takes you down a pathway of discovery that helps you know the patient better and help me problem solve. Just like with the subway driver, the train driver. I really appreciate that example. And I'm going to transition, because you said a word that I think transition us to our next topic on the 9 steps. I want to remind right now our participants on the line, this is the time to put your questions in the Q&A chat. I know I have 1 or 2 already, but we're going to turn to audience questions shortly to close our hour. So know that that's coming. But let's now look at that application of similar surveys, or the perception of patients.
Yeah.
We know that perception drives engagement, and I would argue treatment as well. How staff feel about the populations they serve matter. And that also ties back to that human thread, that common thread concept. Can you talk about that a little bit and give us some of the gems out of your book?
Yes. So, you know, a lot of times, you know, everybody hears about the HCAP scores. What do patients feel about the care they receive, or would they recommend the hospital? But you don't hear any surveys as what does the staff feel about the population they serve. And from my perspective, there could be there's a relationship whether the results for the HCAP scores are good or bad based on what the perception of the staff thinks about the population served. And so I did a couple of surveys, and I asked the team, just an example, what percent of the patients you think are insured? And the proverbial answer was 25 to 30%.
I saw this, yes.
What percent of the patients you think are
literate?
Are literate. And again, it was still the 25 to 30%. And so when we look at the reality, 75% of the patients were insured at Kings County. And 70% of the Caribbean population were literate. And 54%, I think, of the African American population were literate. So when I did that survey, I'm saying, I wonder what it would change the minds of the team if they knew that their perception was incorrect as to what the reality is. It changed the way they value the patients, and it would change the way they engage with the patients when they know what the reality versus versus the perception is. And I think that was very helpful. And I realized you could change cultures. You could change the culture by, and again, the first thing was the patient engagement and cultural competence training, you know, that I've developed, that I've done at different institutions. And when asked at the end of the presentation, this is a series of 8 or 9 questions, but number 7 is what resonates with me. After hearing the presentation from Dr. Beverley, would it change the way you engage and communicate with patients? And across the board, 90% said yes. And they have never looked at it from that perspective.
This shouldn't be groundbreaking, but it feels like it is. Why is that?
Because I think it comes down to lack of human value. And sadly, and it's geared towards more African Americans, Black folks.
Which gets us back to the concept of the importance of racially concordant care, which gets us back to the concept that we have to increase the number of Black people in medical school and going through the medical education process, which gets
Yeah.
us back to the point that we have to protect those learners.
Mhm. Yeah.
So,
And yeah. So, you know, I understand that, and I
yeah,
think it's
yeah.
absolutely correct. And we definitely need more physicians that look like us to take care of patients, because it's been proven when Black patients, like there was an article that came out, I think 2 years ago in JAMA, Black babies in the NICU had a 30% less mortality when taken care of by Black physicians
Right. That's
than
right.
by other groups of physicians.
Yeah.
But for the white babies, there was no difference regardless of who took care of them. So we know that as a fact, you know. But I think in the meantime, one of the things that systems have to do is recognize that cultural competence applies to American-born physicians to foreign-born patients, but also foreign-born physicians to American-born patients.
And
American-born
American-born physicians to American-born patients.
American-born patients who are different than themselves. So there has to be a training. So people can say, well, we don't have enough Black doctors. Yes, we don't. But in the meantime, that does not mean that the care should be compromised. And so there's a lot of articles that prove that when Black take care of Black patients, they do better.
The data is there. Here's the concern, and this was not a question we prepped, so think about this. My concern is that in this societal and cultural space of anti-Blackness, anti-otherness, anti-DEI, anti-inclusion and equity and diversity, as we are on the horn saying we need more Black physicians, we need physicians who understand the Black experience in America, there are forces that are fighting against that and say, no, we don't. We need to get rid of all that. And there are actual processes that are getting rid of those things, not the least place of which is in medical school. What can we do to fight against that? Are there tips in your book? How might we use your book? Again, just a question that came up as we're discussing it. What are your thoughts?
Well, I think it's important. My book is important. I'm looking for medical schools to purchase the book and have their medical students read it and have a discussion and a training related to the content of the book, because the book talks about patients and how they interact. And it will hopefully get rid of the perception once they come to an institution, because if a medical student comes to an institution that's toxic towards Black patients, 6 months later, that person is going to be toxic as well.
That's right. That's right.
And so we can change the dynamic. And matter of fact, I'm meeting with the American AAMC for American colleges to discuss how are they interested and would they be interested in having my book, you know, in the medical schools.
Sure.
Because when I did it at Toro Medical College and the training, and the response from the resident, they said they never heard anything like this before. And it makes sense.
That blows my mind.
Yeah, they said, and it's simple. So it's not, the book doesn't create stress and you got a whole lot of work for everybody else to do and this, that, and no, it's simple. It comes down to value me as a human being.
Indeed.
Simple as that. Simple as that.
You started working your way into our last question before we open up to the floor. And it looks like we just right now just have one question in the queue, but we'll give people a moment. You started down the path of what is it that at the end of the day you would like to see your book accomplish?
I think I would like to see my book accomplish sustainable processes with results. It's not just results for a point in time. It has to be sustainable. And once it's sustainable, then the health disparities and the health for African Americans in particular will improve. There has to be a sustainable results. That's what I would think my book would accomplish, what I would love my book to accomplish.
So let's go ahead and start with the question in the chat. And then if we don't get others, we can go to a couple others. But one of the questions here is, how can we get exactly what you just said? How do we get medical schools to begin to incorporate cultural competency classes in their curriculum? What do we do? What do you see as the pathway to that?
Well, I think we need to be able to form a group, a collaborative group, for physicians that are practicing, for medical students, and for the major the major medical school association, and to have a discussion with them. And that's what I plan to do.
Okay.
You know, because I need to hear what they think. You know,
Sure.
AAMC, I need to hear what they think.
And as you know, we do have, the National Medical Association does have a very close alignment with the AAMC through the Action Collaborative for Black Men in Medicine. And so there is an open pathway. So let's make sure, as one of our esteemed members, let's make sure that we move down that pathway to help us get to that place, because I think that is a really important piece.
And I'm having a conversation, I think her name is Dr. Malika Fair, next month.
Yes. Wait a minute, Malika Fair. I think she's a Detroiter, just to say. No, that's not appropriate for the webinar, but I'm a Detroiter, so I always want to let people know. She is from Detroit. Thank you very much. So we have a couple other things that have come up in the Q&A. Thank you so much. And let me offer, I think one is just a compliment. I'll offer it. Thank you for this presentation. Very enlightening. As a Black nurse educator, I will share this book and its content with my professional colleagues as faculty development, with an end goal of sharing this with nursing students for practice excellence regarding health equity. Thank you so much for that, for sharing that. Here's a question. What advice would you give to patients for better empowerment and engagement with providers? That's a great question. We talked about this just today. What are your offerings there?
Yeah. So what I would recommend for patients, if the doctor, if you're in the hospital or in the doctor's office and the doctor, and the patient and the doctor asks, did you take your medication? Or did you follow directions? And wait a couple of seconds. And if you don't hear the why, say, do you want to know why? I didn't do something. And so please don't write non-compliant in my medical records without asking me why, because it could have a negative impact on my health outcome. And that's what
I think that's an important piece. Not only are you, Dr. Beverley, sharing, like, ask me why. It's almost like a prompt from the patient, but you're also equipping them to say, and please don't put this term in my medical record. So there's something about an educated patient. Now, I know that in some situations that may feel intimidating to the physician or threatening to the physician. Thank you for that, altering your camera. So I just help us think through how a patient might do that in a way that does not cause an unnecessary friction. Can you complete that answer?
It's the patient's right to ask questions.
Indeed.
Yeah, and so and their concerns. So what the patient is saying, do you want to know why? And then if once you hear the story, whether they want to or not, say it. And I would really appreciate, is the way it's said, I would really appreciate you not put non-compliant in my medical record without asking me why, because it could impact my health outcomes negatively.
Because it can impact my health outcomes.
Yeah, negatively.
Good. That's strong. That's strong.
And so that's what I would definitely recommend for patients, you know. So it's not just on a one side fits all. It's for both sides to be able to change. And, you know, it's kind of interesting because Dow Hewlett, who is part of NMA, he sent me an article. I could not believe it. And the article that came out of that internal medicine newsletter came out. And guess what the name of the article is?
Tell us.
Essentially, it's time to get rid of the word non-compliant or something.
Look at this. Look at this.
Yeah, let me see if I get the exact title. I wrote it down somewhere, you know, but could you imagine?
You come up with it, let us know. But it was an article. What was the journal where it was published for our?
The American Internal Medicine.
Internal Medicine Journal.
I'll send you
the time for us to get rid of the term non-compliant. What we talked about earlier today, it didn't go the next step to say ask why, but now that you know that.
But you know what was key about that article, and I may have the title not 100% correct. But what I appreciated in the article, it said maybe we as doctors need to do some self-reflection.
Which is one of your 9 key essential qualities.
You know, so, you know.
So I think Let me slide in one more question before we close, and we really appreciate the participation of everybody on this line. Be reminded that the National Medical Association believes very strongly in amplifying the voices of our members, and so these book events are going to be coming a little bit more frequently. We have probably 3 or 4 in queue before the year is out, and we really appreciate our members who not only take the time to become authors, do the research, do the work, the hard work of getting a book published, but also offer that book for discussion in these NMA lives. And we really appreciate you, Dr. Beverley. The last question before we close out is how can we listen to patients when managed care demands quick visits? What would you suggest there?
I don't think that's a managed care issue. I think what I've experienced, once you see results, it makes it easier for doctors to communicate with patients. And so when you have a patient being readmitted, you know, that's what stresses people out.
Yes.
And so what we found at Kings County, we asked the team, well, was it stressful? You decreased readmission from 30% to 18.7 in just about 2 years. Was it stressful? And the team said, no, it was not. We actually were having fun. you know?
Yeah.
The interesting thing, the clinical team who are actually taking care of the patient would come to the readmission prevention and say, oh, Dr. B, can you help us with John Brown? So there was a collaboration, because once the team or physicians or anybody sees results, it's easier for them to buy in.
Sure.
And so it was not a blame game, you know, it was
the
really,
results speak.
Yeah, it was results driven, but it also was bringing into the conversation patients,
Wonderful.
you know, and I don't have, I may have told you that, but I did a survey quickly of doctors. How many people are taking 5 medications, 6 medications, none, 4, 3. The most number was 3. One person was taking 1. And I said, so could you tell me the medication you're taking? And he said, I'm taking it for twice a day for 10 days. I said, would by chance be an antibiotic? He said, yes. I said, are you compliant with it? He said, well, I'm on my shift. Sometimes I forget, you know, and, you know, I'm tired. So I said, you're taking 1 medication and can't take it on a regular basis.
Right.
But a patient is taking 5 or 6 medications 3 times a day, and you call them non-compliant. So maybe we need to change that dynamic. So he said, well, I'm on my shift. I said, well, patients are on their shifts too.
Exactly.
And then he says, okay, I won't use that term anymore.
I love that.
And so it's a learning curve.
Yeah.
And I said, how many days do you have left? He said 3. I said, could you be compliant with the 3 days?
And that ties it back to that self-reflection. Dr. Beverley, I really enjoy going through your book. Thank you for the privilege of not only reading it, but having the opportunity to interview you and your process and how you got there. I want to thank those of you all who gave up your time tonight to be with us, to learn from Dr. Beverley and to enhance your own, enhance and edify your own education. Thank you for being part of this NMA Live, the National Medical Association, which, as you all know, represents the interests of the 50,000 Black physicians in this country, their patients in their community, is always looking for new ways to offer of ourselves to our community and to our members. And these NMA Lives that are reviews of our members' books are one such way. So please do stay connected to our website. Please follow us on our social media. We are on Twitter, which is now X. We are on Facebook. We are on LinkedIn. Please take the time tonight in the remaining moments before the debate to go on and like us, follow us so that you can keep up with what we're doing. I'm hopeful that all of you all who are online with us will be with us in New York at our convention and scientific exposition. We will be there August 3rd through 7th, downtown near Times Square at the Sheraton and the Hilton. We have lots of great experiences planned for you. So please do get that registration in and get your rooms so that you're there. Dr. Beverley, thank you again. All, please make sure that you find this book, 9 Simple Solutions to Achieving Health Equity, a Guide to Healthcare Professionals and Patients, which is already a bestseller. You better get it before it sells out. Thanks, everybody. Thank you for our production team. Jennifer Young, you are a rock star. Blessings all. Good night.
Thank you.